So in the early days of the pandemic, even as an experienced physician, I felt like a fresh intern nervously awaiting a barrage of disease presentations I'd never seen before. But I also began to feel a second nagging experience of deja vu. It seemed that a disproportionate number, even a majority of those being admitted to the hospital with COVID-19 were people of color. I asked around, and my colleagues and residents corroborated. The data coming out of Milwaukee first, then sporadically elsewhere, and eventually in Massachusetts in my own hospital confirmed the story. While this narrative took just weeks to coalesce, I noticed an analogous pattern in our hospital 5 years ago. In 2015, I was an intern, wondering why, along with some of my classmates, it seemed that patients of color with heart failure were, compared to white patients, more likely to end up on our general medicine service as compared to our cardiology specialty service. What we found has led us to ask a new question on behalf of academic medical centers. How do we repair the costs of decades of racial inequities in care? But first, we had to prove that our initial impressions were correct. Doing so was arduous. How to get the data, how to get faculty to support such a project, all while working 80 hours per week as resident trainees. It was a long, slow process, but we finally got there. Nearly 4 years after our initial observation, we published the results of a 10-year analysis in late 2019, showing how Black and Latinx patients at our hospital, as well as women, were less likely to be admitted to our specialty cardiology service. We also showed that these inequities resulted in higher readmission rates and possibly even higher mortality rates for our Black patients. Right around the time these results were published, I received an acceptance to become a 2020 Atlantic Fellow for Health Equity. Excited to be tapping into a new network of co-fellows and mentors, I felt energized and hopeful that this next stage of the work would be more broadly impactful as we started thinking about interventions. But then COVID-19 hit, and it derailed the follow-up study we were working on as our hospital admission patterns changed fundamentally for many months. I spent long, difficult hours caring for patients who I often felt powerless to help, particularly in the days before any effective therapies had been recognized. I watched life partners say goodbye over the phone, people who were unable, after 50 years by each other's sides, to spend the last minutes physically together. By summer, though, the virus was largely under control in the Northeast, and we could return to building out our racial justice program. At this point, the lessons from the Atlantic Fellows program really began to pay off. Conversations with my mentor, Polly Pittman, one-on-one chats with Kate Hilton, encouragement from my co-fellows, and the project really began to generate some momentum. Our team was able to build together more quickly and comprehensively. We developed an expanded imagination and a more incisive vision. The focus on leadership and organization has been essential. It's been crucial, really, that's been provided by the Health Equity Fellowship. It's helped us capture and harness the anger and motivation people were feeling in the wake of police murders of Ahmaud Arbery, George Floyd, and Breonna Taylor. I was able to take a more decisive leadership role focused on building out a core, highly invested team, a team whose members felt this project was really theirs at an individual and at a collective level. Simultaneously with our twice monthly sessions on equity with Wispelwey as part of the fellowship program, I began to think about what does health equity really mean in the US context of settler colonialism and racial capitalism, a context of historical racism and oppression that has never provided reparations or material reckoning to the descendants of enslaved people. Considering this context in greater detail, it became more obvious why so many of the attempts at addressing health equities in the US have been insufficient. To better understand the role of historical and structural force of racism, I began to reading critical theorists in earnest, Derek Bell, Kimberly Crenshaw, and in the public health realm, Chandra Ford. Equal Health and Social Medicine Consortium founder Michelle Morse and I had meetings with a variety of experts on this topic, from ethicists to historians, lawyers, and economists, thinking more broadly about what kind of response these racial inequities required. Rather than the project falling again into the background as a result of a resurgence of COVID-19, our ideas began getting bolder in response to the incredibly inequitable spread of COVID in the US, to the horrific murders of Black people by police, and to the conversations we were having within the fellowship and beyond. What we landed on was a framework for addressing institutional racism based on that proposed by William Darity and A. Kirsten Mullen in their landmark book on federal enslavement reparations. Acknowledgement, redress, and closure, or ARC. We organized around promoting the idea of a healing arc for institutional inequities, ultimately securing support at the highest levels of our hospital departments to not only fix the processes that led to racial inequities, but to take a much bigger step, to set a new precedent by providing redress through this healing arc framework. The outstanding debt engendered by our medical field and institutions and owed to our patients of color is overdue. I believe that now is the time to start paying it off.